everybody is enjoying a little bit of food to have a little bite. And let me just introduce myself to those of you that doesn't know. My name is Oscar Escobar. I'm a double lung transplant recipient. My surgery was done at the Jackson Memorial Hospital in Miami a year and a half ago. That's when it was done. My purpose in life now, after my double lung transplant, is being an advocate to other patients, to participate, to look for options. Okay. I'm here as a voluntary person to do anything for all of you. My work here, I do it from my heart to pay forward the gift of life that I have received. So I'm here for everybody. My information is in the pamphlets that you received. My phone number is there, so you can contact me at any time. And by all means, I want everybody's participation on the club. Okay. I want everybody to join every time that we have any meeting. Next month, I know a lot of people will be leaving the state because they live Ammar. So we probably will have some online, some of the conferences. And the other thing that I have to say to everybody, and especially to those people that have contributed to this group, thank you. Thank you for your contribution. I don't feel good to mention any names, but you know who you are that have helped me to make all this possible. Okay. The money that you are contributing to this group, it comes back to this group. Everything, it just comes back to all of this. So thank you again. And with that, I'm going to introduce Dr. Ammar Abu Sulb. He's a cardiovascular internal medicine from NCH. Doctor, thank you so much for being here. If you don't mind, let me just
It turns on.
like always, some technical issues that we always have to work with. New technology, okay? Anybody have any questions for me? I'm all open for any questions related to my issue, my condition, pre and post my surgery. If anybody is interested, by all means, I'll let you know. Anything and everything. And I feel fantastic. I feel really good. Okay. Every day I'm grateful for this gift.
Are you on anti-rejection medication for the rest of your life?
Yes. That's a commitment for the rest of my life. Mhm. That's the prognosis, I know. Okay.
What about it?
That's one of the
Yeah.
things that I know. I don't
So
agree
that's why
with
I
the
know for
doctors.
this. Oh, fine.
Because normally they said, okay, well, it's about 5 years. Because those first
Yeah,
5 years
Just need to.
are the most critical. The first and second year is the most critical on the person.
I just need to.
Depending on how it goes, those first 2 years dictate the next 5 years. But I already know people that is being with the double lung transplant for 16 and 17 years. One of those participate very active in one of the groups that I support as well, which is PF Warriors. That group, it's on Facebook. They do monthly meetings as well. And one of the persons that does the meetings, double lung transplant, 17 years. The next person that I know is, it's got 12 years. One of the patients here, Mark, it's 7 years. So I don't agree with the doctors when they tell you, oh, most like, or the numbers, because they go by the numbers. And I don't like when they tell you that they go by the numbers.
I don't like
Sorry
it too.
about that. Because when you go to
Yeah.
one of the offices of the doctors and
This one.
you're a prospect candidate for a lung transplant, they start giving you percentages and numbers and things like that. One of my appointments, one of the hospitals, they started to talk about that first visit, second visit, third visit. And then I just got, fed up with that. And I stood up and I told the doctor, listen, doctor,
Yeah.
you see me right here, right? I'm one. I'm one. I'm not a number. I'm not a percent. I'm right here. And I want to live. I want to have longer life. I want to have better quality of life, especially because my motivation, main motivation for this was my family. I was just talking to her. I got a small kids that I wanted to see grow. When I was diagnosed, I felt horrible. My whole world crumbled completely. I mean, I was in pieces. The first thought that came to my mind when they gave me the diagnosis, which was pulmonary fibrosis. And the second thing that she told me was, it's an incurable disease. The only solution that we have for this is a double lung transplant. My world just crumbled completely. So I thought of my kids, and the first thought that I had was, what have I have done bringing these kids to this, especially the little ones? My youngest is 6 years old. He's been growing up with me with this disease, basically. Because I was diagnosed when he was less than a year. So just imagine. So I was thinking about them, and that was, like I said, my main motivation to look forward to see them grow up, help them. And now that I got this, now that I went through double lung transplant, I can do a lot of things that I couldn't do. I can go and ride a bicycle with them. I can go for a long walk with them. I can just run with them, not a long distance, not a marathon, but I can run with, especially right after my level. Okay. From the 4 kids, I got that one that is 6, and the oldest is 15. So just imagine, only between 2 boys, 2 girls. On top of that, I have another family, an adult family, that it was my support. My wife and my adult kids, they provide wonderful support. Okay. And that's the reason why I want everybody to know about this. Because yes, you need the support from your family, you need the support from your friends, the community, and these groups. These groups, believe it or not, it will give you emotional support that sometimes you don't have. Know from your family, because if you're doing a little better, they will tell you, oh, tough it up. You're looking good. Tough it up. You look good. But inside, you die day by day. And it's more and more difficult every day to accomplish tasks, to do something that normally you do it freely. So by all means, participate on this group, be part of it, give me options, give me ideas. I'm open for all ideas, to everybody to bring me ideas and to sign up on the website to suggest for suggestions what we should bring, what should we talk about it, and any other things. Maybe go lunch with everybody, have a big party one of these days, and get together, and everybody just talk about our issues, each other.
Not going for some. Yeah, correct. Yeah, we have it here. We're not coming. It's not coming on the TV.
It's in HDMI too. And it's on.
Should be on there. So it is.
I know. Try to manual turn that tape. The middle one is just not turned on. It's red.
Now it's on.
There you go. There you go. That's it.
Correct. It's just
There it goes.
yeah.
It's on.
It's on.
It's on.
Quest
But it's not.
HDMI.
should be. Oh, yep.
HDMI 2. There you go.
Yeah.
Yes.
You
Oh,
might
they
be
need
right.
batteries?
You might be right. You just need one screen. Oh, we should be there. Yes, yes.
You'll see it right there.
We are there. Yep.
All right.
Yep.
Perfect. Now we got this working. Again, anybody has any questions for me?
Yep. Perfect. Okay. Perfect. Yay.
There you go.
I know. Thank you so much, Oscar, for filling that void. So, I mean, this is such a great kind of speech what you said, Oscar. And then like I said, I mean, I've been actually I started med school in 20 in how long has it been? 2010. So I've been like 16 years doing this as well, like in the medical education, and about now 9 years working as a physician. And I mean, I can tell you that like what Oscar just said is one of the core issues or core ideas I do believe in, which is because all the time I have patients walking into my clinic or the hospital and saying, Doc, like I see the numbers. I see, for example, my blood level is this, my the pumping function number is this. What does that mean? And most of the time, actually, I give them usually this answer, which is put the numbers on the side. How are you feeling? Because I mean, we do respect the numbers. I'm not disrespecting the numbers or ignoring the numbers, but at the same time, the most important thing is how are you feeling? Because that's in the end, that's what's important. And I've had instances where patients would have what we describe as severe disease, but they're feeling it great. They're on the bike. They're doing what they want to do, and that's what's important. I mean, is the severe disease important? Yes, but that is not the most important thing. The most important thing is you, the patient. How are you feeling? How are you doing? How can we help? I usually that is usually my question is how can we help? What can I do to improve both your quality and longevity of your life? That's the most important thing. Okay. So and again, thank you, Oscar, for giving me this opportunity. And to be honest, usually my audience is or kind of this group of people is usually not my audience. So for me to be able to understand more my audience, who here does have a diagnosis of lung disease? Raise your hand.
Diagnosis of what?
Lung disease. You were given a diagnosis of a lung disease, a lung disorder. Okay. Who here, so kind of in the area of diagnosis, who here was told that they have COPD? Okay. Who here was told that they have something called interstitial lung disease or pulmonary fibrosis? Okay. And who here is a recipient of a lung transplant? Okay, good. Is there anybody who is being evaluated for a lung transplant? Okay, perfect. Okay. So, I mean, as you can see, I'm a cardiologist. Lung is not my specialty. However, it's really close, really close. We work together kind of really close with our pulmonary colleague, as well as the heart works really close with the lungs. But it's I mean, the thing about the body, there's no organ that can work by itself. It's all the organs work together for us to be able to do what we do every day, which is so many things. And when you think about it. It's all kind of a nice flow of functions between different organs. It's really mind blowing when you understand the function of each organ, and you also understand how once you have a organ that is suffering, the rest of the organs have to pick up the slack. That's what we describe. Okay, and that's how our bodies work. We do have a margin of error, but that margin is what we always try to work with in patients who have a organ or single organ disease or even multi-organ disease. And that's what the main goal is, again, to improve the quality and longevity of the patient's life. So I'm going to walk you through kind of a little bit about the heart, as well as then afterwards how kind of things are from a cardiology perspective. How do we see kind of patients with lung diseases, and then how do we what is our role in patients who have pulmonary diseases? So let's get going. Okay, so this is just kind of a quick overview, just for you kind of to give you an idea what we're going to talk about. Just kind of how the heart and lung interact, how your lung problems affect your heart, and vice versa. And why is it hard to tell the difference? It's always challenging for physicians and for sure patients to tell which one which is causing which, right? And why exercise, or in this case, pulmonary rehab, helps both, and when you should be concerned. Okay, so the cardiopulmonary interaction, and I'm always go up for a good kind of history lesson. Okay, so actually the idea or the interaction between the heart and lung came to kind of the picture about 3,000 years ago, back in ancient Egypt. In ancient Egypt, the Egyptian thought the heart looks something like this: a circle in the middle with 8 blood vessels coming out of it. And the over time, over the next 4,500 years, actually, the journey of understanding the cardiopulmonary interaction, or the heart-lung interaction, took a course over different regions of the world, primarily kind of in the Middle East to kind of the Europe, until starting with Alexandria, and then the library there, all the way to William Harvey in the kind of mid to late 1500s, when he was able to develop or actually kind of paint the right picture of the cardiopulmonary circulation. And it actually started with something like this, and this is the first picture that was Erastus, that was kind of an ancient what is around today's ancient Greek, and they actually thought there's air inside the blood vessel, which is, of course, fast forward to 1500. That is actually what can cause sudden death. So it actually can kill you if you have air in your blood vessel. So there is actually no air in the blood vessel. But you can kind of imagine how somebody thought of it. And I always find it amazing kind of how things progressed over history, because somebody sat and said, there's air that goes into the lung. It has to reach the organs. It had to reach the organs somehow. And somebody thought that there's definitely air inside these pipes or these blood vessels. But that's actually, of course, not the case. And all the way to the far left, where William Harvey, like I said, developed or came up with that closed system, where you have well, this is probably kind of most, if not most of you have seen this, which is you have the deoxygenator, the blue blood coming back to the lungs to get oxygenated, and now you have red blood circulating, and that circle keeps going all day. So, but why does your body needs oxygen? And that's kind of, it's a kind of a simple question, but I want to just kind of take you through the basics, and then so you have a good understanding when we come to a little bit more down on our talk. And I'm gonna go over the oxygen journey. And the oxygen journey starts with inhalation, right? You take a deep, you inspire, you take an oxygen. That oxygen goes to your lungs. In your lungs, an exchange process happens, right? Your lungs gives your blood oxygen and takes away carbon dioxide. And that is the exchange that happens in the lung. Now you have oxygen flowing into the blood vessels as it is tagged on the red blood cells. That's why when your blood level is low, you feel very short of breath, is because you do not have enough oxygen in your blood vessels. So it goes to the rest of the body. When it gets to the tissues or the organs, it does the other way around, which means that it gives them oxygen, takes carbon dioxide, and then goes back to the lungs, and that process keeps on going. And why is oxygen important? Because oxygen plus fuel, which could be your glucose or your sugar or your fat, equals energy. And energy in the body, the currency for energy is not oil, it's actually ATP, adenosine triphosphate. That's what we describe as the currency of energy in the body. And like I said, the byproduct of that energy production process is carbon dioxide, which is what we get out from our body when we expire. So when we breathe out, carbon dioxide comes out. Okay? And that is the journey of the oxygen in the body. And now of course, who pushes that circulation in the body is the heart. And the heart, or the pump, is made of different structures. Usually I tell my patients the heart is made, if you look at this room, the heart is made of 4 walls, doors, plumbing, and electrical. So you have 4 walls, which are the 4 chambers, the doors, which is the 4 valves, plumbing, which is what people get stents in, right? So when you have an intervention cardiologist or a cardiologist who put in a stent, is usually they'll say you're the plumber. That's how we kind of describe them. And also, if anybody, does anybody have a pacemaker? Yes, a pacemaker. So you probably have a heart electrician. So you have, that is also, so when you have too much or too little electricity issues, that's an electrical issue. And you can imagine that's why some people have electrical issue, but they have no valve issues, because again, it's possible where you don't have lights, but the room is looking fine, right? Or the doors are looking fine. And that's how the heart is, which is, it's different. It's these 4 components. And that's why sometimes you might end up seeing multiple heart specialists, is because each one of those are actually as a specialty by itself. So the blood vessels, and just to kind of give you an idea, you have blood vessels leaving the heart and blood vessels coming back to the heart. The blood vessels are leaving the heart. Mainly there are 2, which is one is the pulmonary artery, which is the heart, the blood vessels that leave the heart to the lungs. And then you have the aorta, which is the blood vessels that leave the heart to the rest of the body. Okay, and there are blood vessels returning to the heart, mainly the blood vessels that are bringing blood back from the rest of the body back to the heart, or from the lungs back to the heart. And I know it sounds a bit confusing, but like I said, I mean, I kind of to give you an idea. I know, and I'm sure kind of down in our talk, you kind of have a better understanding of what I'm saying. So the ones in the blue are the blood vessels returning. The ones in the red are the blood vessels leaving, and you have the 4 valves. So kind of, oops, sorry. Yeah. So, okay. So, yep. So the blood, the area, or the half of the heart which is in blue, is the half that receives blood back from the body, and the part in the red is the part of the heart that pushes the blood to the rest of the body. Okay, and like I said, between those 4 chambers, the 2 top and 2 bottom, you have valves or doors that regulates the flow between them. So, and the heart, or the pump, needs to pump the blood to the lungs so it can get oxygenated, and then it needs to get it back from the lungs, and then pump it to the rest of the blood to deliver that oxygen to the rest of the body. And then once the oxygen is delivered, it goes back to the heart, and so it can repeat that cycle again. And as you can see, there is a left side which is responsible to push the blood to the body, and there's a right side which is responsible to bring the blood back and pushes it to the lung. So there's left and right, and that is very important, because us as cardiologists, this is how we see the heart, because the heart, as you can see, is very complicated. So to simplify it, the cardiologist came up with the idea that you have a left side and a right side. And believe it or not, these symptoms, or patients how kind of people, when people have issues within their heart, the symptoms are very different depending on which side of the body you have a problem with. And the average heart rate is 60 beats per minute. And with every beat, we eject about 60 to 75 milliliters or cc. So that's about 2.1 to 2.5 ounce. And so that's in a minute, you have to times 60 times that 60 to 75. So that turns about almost kind of, we roughly estimated as 5 liters of blood every minute. So, and you have 60 minutes in every hour, 24 hours a day. So that's about roughly, and I calculated, it's about 7,200 liters of blood is pumped every day in the heart, by the heart. And that's, as you can see, that's a lot, and that's a lot of work. Okay. But the lungs, like I said, it's in direct contact, as you can see, with the heart, and it receives all that blood that the heart is pumping, and to oxygenate it and then send it to the rest of the body. So just to kind of remember, there's a left side and a right side, and I'll tell you in a second why that is important. So to put it all together, I might kind of missed a few parts or some things did not make sense. So I kind of put in this video, so just kind of give you an idea. So the heart sits in the center of your chest, in the mid cavity. It's about the size of your fist. So if you make a fist, that's probably how big your heart is. And there's a right side and a left side. And the connection between the blood vessels sending and receiving the blood is called capillary. And that's where those capillaries, or this kind of mesh network of blood vessels, is where oxygen exchange happens in the body. And this is kind of to give you an idea of how much the heart works. So the heart gets all the blood from the body, top part and bottom part, through 2 blood vessels, as you can see. And it goes to the bottom portion, then the top and then bottom portion, called atria, top and bottom, called ventricles. And then pushes it to the lungs, where it gets oxygenated. And now you have nice oxygenated blood coming back to the heart. Again, top, bottom, left atrium, left ventricle, and goes through the aorta to the rest of the body to deliver that oxygen. Okay, and on the right side, you have 2 valves. One is called the pulmonary and the tricuspid. And on the left side, you have the aortic and the mitral valve. Okay. Questions so far? I know it's a lot. Good? Okay.
I do.
Yes.
What would the different symptoms be, let's say, between left or right-sided heart problem?
That is an excellent question. We're going to get to that. We're going to get to that towards our topic. So I'm just giving you kind of an idea, and as you saw, kind of the connection or the proximity between the heart and lung is it's too close, right? And so that's why a lot of and there are the two are, and kind of it's the organs which are right in tandem sequentially after each other. So you can imagine that a slightest error in one is probably going to affect the other somehow, some way or another. And that's where we get to the prevalence of heart and lung diseases. So heart diseases remain the leading cause of death in the United States. About 47% of US adults having high blood pressure as a major risk factor. So almost half of the population. That's how prevalent high blood pressure is. Cardiovascular disease is the most common comorbidity in patients with COPD. What does that mean? That means that if you have if there's a patient with COPD, the next thing we worry about right after is heart diseases. So that is how common heart diseases are. And about 1/4 of patients with COPD have some form of coronary artery disease, and about 20%, or one in every 5 patients have some form of heart failure, and about also around that same number, they have experienced some form of heart attack. Those are just numbers. And interstitial lung disease, also the prevalence of coronary artery disease is, as you can see, it varies widely. Why? Because there's different severity of interstitial lung disease, as well as many other factors that plays into that. And restricted pulmonary pattern also, it affects less. So that's about 30 to 12% of the population are associated with, and it's associated with 2.3 or 2 times higher prevalence of heart disease. And why is that happening? Because the risk factors for both, the risk factors are the same for both, right? For example, smoking can put you at risk of getting COPD as well as getting heart disease. Diabetes, same thing. So that's why, because these kind of conditions, they usually tend to share the same risk factors. Pulmonary hypertension is when, and we're going to talk about what kind of that means. Pulmonary hypertension is when the pressure inside the lung blood vessels goes up.
Yeah, I have pulmonary
Hypertension.
One of the reasons I came today to try to understand that.
Yes, and we'll talk about it and I'll explain what that means. And pulmonary hypertension is, again, it's not the blood pressure you measure. That blood pressure you measure is the kind of these, what we describe as the systemic blood pressure, meaning what's your blood pressure inside all of your body. But pulmonary hypertension is a different entity because there's, so to kind of give you an idea also, there's brain pressure, so called intracranial pressure. So there's the systemic pressure that we all measure in our arm, but also each organ kind of in some way or in some way or form have their own blood pressure. And that's again why we have different doctors for different organs. It's because you come to these small details and nuances that needs to be studied, and you need somebody who's very competent and understands what they're doing to be able to deal with it. So pulmonary hypertension, about 66% of patients with end-stage lung disease, they have about 66% of patients with pulmonary hypertension, they have right-sided failure. And I'll explain why that percentage is high in a minute. And arrhythmias, a lot, because when, especially in patients with COPD or in general patients with hypoxia or low oxygen level, they tend to get more heart rhythm issues. Why is that? Is because low oxygen tends to mess up with the heart electrical system. Okay. And I just want to kind of lay out the fact, not to scare you or make you kind of concerned, but just to lay out, to make you understanding of kind of how is important is to address your health. And so kind of we don't want you to get other problems that are associated with the problems that you already have. Okay. So how does lung diseases cause heart problems, right? That's a big question. And just to kind of explain to you, and this is actually a very complicated topic in medicine, okay? So if kind of it doesn't make sense, that's completely fine. It took me a few years to understand this, but I'm going to try to simplify it in 2 minutes, okay? The concept of hypoxia versus hypoxemia, okay? And they're very similar. The difference is hypoxia or hypoxemia is when you have low oxygen levels in the blood, while hypoxia is low oxygen levels in the body, okay? Now, usually if you have hypoxemia, meaning you have low oxygen level in the blood, means you have hypoxia or low oxygen levels in the body, but it's not the other way around, okay? Why is that? It's because you can have, for example, you can have low oxygen levels in the body, but even though you have enough oxygen in your blood vessels, okay? To give you a kind of, I'm gonna make it more simple actually. So if the oxygen carrying car or vehicle in the body is your red blood cells, right? But if you have small red blood cells or not enough, then although your content of oxygen in the blood is normal, the total content of oxygen in the body is low, okay? Or sometimes if you have a car that it's not working, right? A red blood cells that are not working. Some patients have diseases such as sickle cell. Those cells cannot carry the oxygen throughout the body, so they will have low oxygen levels in their bodies. Or sometimes a blockage, right? If you have a blockage in a blood vessel, right? You have normal oxygen in the blood, but the blood is not able to reach that organ, and that's actually what happens in heart attack is you have normal hemoglobin, right? Your blood level is normal, and they have no issues in carrying blood, but this just the road is blocked. You have a blockage, and that's what happens. So just kind of understand there's two different kind of mechanisms or different mechanisms of how you would have low oxygen levels in the body. Okay, so but also to kind of also go more into details, there's an interaction right between the heart and lung, and Usually, or when you have breathing problems or having a hard time breathe, it will have some. Like I said, remember I said somebody has to pick up the slack, and a lot of times the first organ to pick up the slack is the heart. So when you have breathing problems, that's going to make your heart work harder. The heart gets tired when your lungs are under stress, okay? And when the heart is overworking or hyperworking, okay, that results in hypertension. Hypertension, which means elevated pressure, it's the hypertension is either on the left side or on the right side, okay? And why is that? Why is that elevated pressure can be on the right side or the left side? The reason is you have, imagine kind of, and I'm going to go back to, so imagine you have point A, B, C. The blood is trying to get from the heart to the lung and back to the heart, right? It depends on where the problem is. Is the problem in going from A to B or B to C, or it's actually both? And depending on where that problem is, it will we kind of decide whether it's a right-sided issue or a left-sided issue that's causing your pulmonary hypertension. So, so that's why lung diseases, they lead to the heart diseases, and we divide them into left and right, or like I said, both. So pulmonary hypertension basics. And what I want you to understand from pulmonary hypertension, like I said, it's an elevation of the pressure inside the blood vessels inside the lungs. And that is what pulmonary hypertension is. I mean, I'm not sure if you want to kind of know the number. Usually, if anything above 20 millimeter mercury, that's when you start to see an elevation in your pulmonary pressures.
Yeah, I have 3.8 centimeters at the pulmonary artery, at the ballooning of it.
Correct. That is probably the size is when you get to almost 4. This definitely means that you have elevated pressures within the lungs. You have elevated pressures within the lungs. Yes, you said yours is 3.8, but yeah, I mean, usually that's kind of what I'm saying.
How do you tell if you have pulmonary hypertension?
Good. And we're going to come to it. There's different ways where we can measure the pressure inside your lungs, okay? But to give, it's, I mean, to you, is to both of us, it's very important, okay? It's very important, I would say, for you to know that, do you have it or not? For us, is where that's where the kind of the numbers is kind of to us, it becomes important because depending on that, we know whether we're making improvements or we're not. And that will determine whether we need to change our approach to it or we can continue what we're doing.
What can you do about if you do have it? What can you do about it?
I'll tell you in a second. So somebody came and said, okay, this is, again, as you saw, it's getting complicated. Somebody has to simplify this, okay? So the World Health Organization, or the WHO, came together, and this was actually a time, now it's been about like above more than 10 years, where they came together and they said, we need to kind of categorize this into different categories so we can understand it, okay? Because again, it's complicated for the doctors, it's complicated for the patient, somebody has to simplify it. And they said, we're going to divide it into 5 groups. Group number 1 is patients who have something called pulmonary arterial hypertension or primary arterial hypertension, meaning the blood vessels in the lung, they decided they want to close. So they tighten up. And again, always keep in mind when I'm going over these categories, keep in mind point A, B, C, right? Heart, lung, heart. So imagine trying to go from point A to B or trying to go from point A to B on a highway. And instead of having a nice 3-4 lane highway, you have 1 lane. It's going to make your job harder, right? Driving on that road. So the same thing with the blood. The heart is trying to pump that 5 liters to the lungs, but it's facing a very tight, narrow blood vessels, that tight, narrow kind of road. So the heart has to work harder, and hard work means hypertension, and eventually patients with primary arterial hypertension or pulmonary arterial hypertension, they develop right-sided pressure hypertension, right-sided pulmonary hypertension, right? Because the blood is trying to leave from the right side to the lungs. So that's category number one. Category number two is as the blood is trying to leave the lungs, so going from point B to point C, it's meeting resistance inside the heart. And those are categories of patients who have heart diseases who end up having lung issues. So in a story of who came first, the chicken or the egg, in this case, the heart was the problem that caused the lung problem. So that's category number two. Okay. Category number three is when patients who have lung issues that cause the heart to work harder, such as patients with COPD or interstitial lung disease. Because when you have these diseases, it's not only the tissue or it's not only the airways where oxygen goes in are damaged, but also the blood vessels. So maybe it's not the first manifestation is for those patients to have hypertension, but over a long period of time, when those blood vessels are damaged, the heart has to work harder to push blood into these damaged blood vessels and then back to the heart. So also again, category number three is the same as category number one, is usually it's a right-sided issue. So you have right-sided, left-sided, right-sided issue. And then group four is patients who had multiple, something called pulmonary embolism. So that's why CTEF stands for, which is chronic thromboembolic pulmonary hypertension, meaning it's usually patients who have one lung clot and then they end up having another and another and another. And what happens with these lung clots is they close these blood vessels and eventually the heart has less blood vessels to push blood to in the lungs and they end up getting high pressures within the lungs. And group number five is it's kind of everything else. It's whether it's the mix, whether it's we don't know what it is, whether so kind of it's kind of what's left of once we categorize all the four. We have patients who we're not sure what's going on, or it's a mix of multiple things. So they fit in category number five, and those are less than 10% of patients.
What is the left atrium?
So the left atrium, usually if you have problems, and to your point, you said left, right? So usually it's a left-sided problem. So it's probably it's a group two, meaning as the blood is trying to leave the lungs back to the heart, they're facing a problem or an issue that's causing the blood to back up to the lungs, and that eventually causes increasing the pressure in the lungs. Does it make sense? Yeah. And if it doesn't, somebody said, no, it's still complicated. All I want to know is the problem is going from point A to B, which is pre-capillary, meaning pre-lung, or is it intra or intracapillary or pre and post, which means it's both a mix of before and after, or is it a post-capillary, meaning is the problem is the problem that's causing the high pressure within the lungs after the lungs? Okay, so again, I'm just giving you an idea. I don't expect you to memorize, or you're not going to be tested on this. But I'm just giving you an idea so you understand kind of how do we see things from our end. So when we you might hear those terms that I just said kind of thrown around between doctors, and that's just to simplify our language to be able to treat patients quicker, right? Because if we're going to start kind of going into how everything started, it's going to take time, right? And then we don't want to waste time on trying to kind of explain everything from that takes a lot of time. So we developed our own language, and this is kind of part of our own language. That's why I know sometimes, and I am guilty of it. Sometimes kind of you would say doctors like they only spoke for 5 minutes, but all we need is sometimes are these kind of simple words, and it will give us the whole picture. Okay, so this is just kind of a quick idea. I'm not going to go into the details. It's just I just wanted to show you how this is a cycle, right? And the problem with the cycles is they're nice when they're working, right? But when the cycle is when you're stuck or when they are working too much, that's when you kind of start circling kind of or having that vicious cycle that twirls and eventually kind of does not end up in a good place. So that's why sometimes our intervention is basically us trying to break this cycle. And this is and that's kind of what we try, what we do when we think of these kind of conditions. So, for example, I'll give you in patients with COPD. COPD leads to hypoxia or low oxygen in the body, right? And low oxygen in the body, the heart perceives it as there's not enough blood. So the heart starts pumping more. And when the heart pumps more, it's pumping more to the lungs. The pressure in the lungs goes up. And the heart after some time gets tired out. So the pressure, so the heart starts failing. So see kind of how it is a vicious cycle, and it's very important for us to break that cycle and also break it as early as possible. Okay, because eventually the heart failure is going to cause more fatigue, more respiratory muscle weakness, and on top of all of that, also in the background, there's a lot of increase in systemic inflammation. So, but why is it hard to tell the difference? Is because usually these are the symptoms that patients have, right? Which is they usually have headache, shortness of breath, fast heartbeat, coughing, wheezing, confusion, bluish skin or lips in some cases, right? And I can guarantee you, if you get 100 doctors and you tell them you have these symptoms, without nothing else, nobody will be able to tell where the problem is coming from, especially the heart or the lung. Those are common symptoms that are caused by both. Okay, and both actually can cause the symptoms whether on rest or exertion. So it's really hard. Like I said, as you saw, there's a close connection between both, and so it's very hard to tell which is which, causing which. But there are ways to differentiate. Kind of answering your question. So how do we differentiate? Is we have certain ways to try to understand kind of where the problem is coming from. And again, for us to simplify it, we decided that, or we thought about it, or we think about it in a way where is it a right-sided issue or a left-sided issue? Now, what can help us to decide that? A good history and physical exam. So that's why it's very important for us doctors is to sit with our patients and understand. And that's why, I mean, I'm sure that many of you have met more than one doctor and they all ask the same questions. And not because we like to be redundant, it's because we try to understand. And a lot of times the answer is in what you guys are telling us. What are your complaints? What are your concerns? As well as our physical exam. So that's where we get the most information from. The next thing that gives us information is blood tests, such as a complete blood work or basic metabolic panel. And those were checking the levels of your hemoglobin, because, for example, anemia or low blood level can cause you to feel these symptoms, right? And basic metabolic panels, sometimes when you have other organs, such as the heart, the kidneys, or the liver, those are also problems, and those can also cause you the same symptoms. And the one I underlined it because I'm sure at some point most of you have had it. It's called arterial blood gas, which is where we kind of put a needle inside an artery to take a sample of the arterial blood, because it tells us how is your blood gas doing. Because we want to know, are you hypoxic or are you hypoxemic? And I'm sure some of you will remember this if I said it, and maybe some of you might kind of swear at me. But it's that very painful needle that they insert in the wrist. Yeah, and that is, I know it's hard, and again, we apologize for it, but it's very important. That's a very important test, and we do it because, like I said, it gives us an idea about that hypoxia versus hypoxemia, and also it helps us understand where the problem is. Gives us that kind of single blood draw, that small needle, gives us a lot of information, and that's why we usually check it, is because of that amount of information that it provides. And then there's non-invasive testing, such as an echocardiogram. Because an echocardiogram, we look at the heart, we see the structurals. Again, remember the walls, the doors, but we cannot check plumbing or electrical on it. But we usually check the walls and the doors, because if those are fine, that's very reassuring. Now we know where we start looking at other places, right? And also a CT scan, or kind of a heart CT scan or a heart MRI, or test that usually are done, of course, for lung issues, but also we do it for heart issues. And also sometimes we do what we describe as an exercise invasive testing. So we take samples of the blood while you're doing exercises, or sometimes you're not. Sometimes it's in the cath lab. We do what we describe as a right and left heart cath. And I'm hoping now you understand what when we say right and left, now you understand why we do that. It's because we want to see, is the problem on the right or is it the problem on the left? So a heart catheterization, which probably some of you might have or have not heard of at least, which is it's a procedure where we go through the arm or the groin to check the blood vessels, usually of the heart, but also we take samples of that left side. A right heart is we go through the vein, so that blue side of the heart, and we check the pressures, the the level of oxygenation, and multiple things on the right side. So answering your question, that is kind of how we know the difference between whether it's a left or right sided problem after we gather all that information. So I know that kind of it seems like doctors are ordering a full panel of workup, but that's why we do it. And again, it all goes back to that complexity of this amazing body that we live in, on trying to understand really where the problem is, because we don't want to fix something that is already that's not broken, right? We want to kind of fix something that needs to be fixed.
So if the problem is on the right side and the left side, there are different treatments for it.
Correct. Absolutely. And that's where we get to this. How do we treat it? Medications. So I don't want to kind of bother you with this, but there's a lot of the medications. There's a lot of different medications that we give.
Yeah, I have been on both so my right heart.
Pressures. Yeah. Yeah.
I'm curious, I have been told by people that these medicines were really terrific and will totally solve the problem. Is that true? How do they work?
Yeah. Yeah. I mean, the short answer is these medications are great. Otherwise, we would not be prescribing them. The problem is they're not as great as the original kind of our original creation, right? It's they're these medications, they help. They're if you have been prescribed a medication, those medications have went through rigorous studies to prove that they do help, and that's the reason we prescribe them. Now, help is different for different patients, right? And that's where a lot of our treatment is kind of is directed at, because again, these different medications work differently. So we try to understand first of all what the problem is, right? Because that's half of the solution is understanding where the problem is, and once we understand it, we tailor our treatment to it. And that could involve medications, like I said, to lower the pressure, sometimes to lower the pressure inside the heart or the lungs, or both in this case, right? Sometimes the medication is not the only intervention. Sometimes things need to be addressed in a more invasive fashion, such as transcatheter management approaches or even surgical approaches. So depending on the problem, like I said, always half of the solution is identifying the problem. If you identify the problem, it's actually treating it becomes a little bit easier. Okay. So answering, I mean, unfortunately, we do not have a perfect medication for every condition. We do have for certain condition, but not every condition. And sometimes, in some of the therapy that we provide, it's either to slow down the progression of the disease or stop it. But sometimes it's not we can't reverse the progression or what the damage that already happened. But sometimes that's all it needs. And that's why it's a very important in a lot of cases is to catch this as early as possible. So I'm hoping kind of from my talk is not only for kind of this amazing group of people to understand this, but also for you guys to pass on the message that don't wait. If you're concerned, it always starts with your primary care doctor. If you're concerned that they're the first person to reach and say, hey, I'm concerned about this. And then the next would be all these specialists in different specialties to help you kind of, like I said, that cycle is to break it to break that cycle early in the process as soon as possible. Okay. Go ahead.
How important is it to know that you have pulmonary hypertension? Because my lung doctor hasn't done any tests to determine that. I have interstitial lung disease. I also have anemia, which means low blood sugar.
Yeah, it's very important to know, both for, like I said, the physician and the patient, because again, we're working as a team, right? So because we are seeing you 30 minutes to 45 minutes a day in maybe every 1 to 3 months, right? So the rest of that's why it's a team, and that's how we should be thinking about it, because there's work that we do together in the clinic, but there's a lot of work that you guys are doing on the back end, right? So it's very important for you to know. That being said, you might say, Doc, like, how come I didn't get a right heart cath, or nobody checked the pressure inside the lung? That is probably because they did check it some way or another. So for example, I'll give you an example. Echocardiogram gives us a good estimate of what your pulmonary pressure is. So from that ultrasound of the heart, through different ways, we can tell what the pressure inside the lung is, to a good kind of with good certainty. Now, if we decide, so the question becomes, so why are we doing a right heart cath if you can tell from the echo? The answer is, in certain cases, the echo has limitations, the ultrasound of the heart or whatever modality we did, because also the cardiac CT and the cardiac MRI can help us determine that, okay? But whatever modality we used had limitations, which is why we decided to do a bit of an invasive kind of procedure, which is that heart catheterization. So we kind of always the idea is to avoid any invasive testing as much as possible, but we only resort to it when we really kind of when we have question marks or we need a tiebreaker, and most of the time these invasive tests are tiebreakers.
So is it the pulmonologist who does these tests?
The pulmonologist could order an echocardiogram. That would be kind of if they are concerned. Absolutely, they can order those tests. But also, I mean, it's a test that we usually kind of, as cardiologists, we almost always order it. But a pulmonologist, I've had a lot of my pulmonary colleagues ordering those echoes, and based on the echo findings, they see things that they refer to us as cardiologists to investigate further.
How does sleep apnea interfere with the oxygenation?
That's a good question. Sleep apnea is defined as period at nighttime, right? Nocturnal sleep apnea is defined as period where your breathing stops, right? And usually it's more than, if I remember correctly, the definition is more than 1 minute where your breathing stops. And it's, of course, it's evaluated with a sleep study, right? And what happens is that your breathing, or when the breathing stops, and that's most of the time is because of inability of the air to go into the lungs. The breathing stops, the oxygen drops. Okay, when your oxygen drops, eventually it's one of two things are going to happen. Either your brain is going to wake you up in some way or another, to, of course, avoid dying. So either you wake up, or you kind of toss and turn in the bed, or it's going to drive your breathing so fast, or both. Okay, so it's where you have period of time where at night where you have your breathing stops and all of a sudden it picks up, and that pattern, because the oxygen follows, where your oxygen drops and then it goes up, oxygen drops and it goes up. It almost is the same as exercising. So that's why people with sleep apnea tend to have a lot of kind of fatigue in the morning. They're sleepy, is because instead of like you being well rested at night, you're actually kind of almost exercising in your sleep. So that's why. And also that period of low oxygen in the body, it causes you to have very hard to control blood pressure, increases your risk of having heart diseases, increases your risk of valve diseases. It's sleep apnea is definitely one of those kind of silent problems that are not as known as it should be. I think us, even as doctors, we not only patients, us as even doctors, we underestimate the importance of diagnosing and treating sleep apnea. That's a very specific question. But that's so on the echocardiogram is that's the number that you mentioned is our estimate, which is the right ventricular systolic pressure, which is what is the pressure that the heart is needing to push blood from the heart to the lung, right? And remember that number I told you, the normal is anything less than 25. So 46 is kind of mid-range. It's not high, but it's not low. It's kind of mid-range. What would I do is I would kind of, I mean, if that is the first time I see this, and the patient is, or the patient is having symptoms, we usually definitely investigate it further, trying to understand what's causing the pressure to go up. If there's no symptoms and I have a reasonable explanation, we usually try to treat that kind of reason and then follow up on it in a few months with usually another echocardiogram or some form of measuring that pressure, and we see how that's kind of changing. So it again, and the answer it depends on kind of how the patient is doing and what else is going on in the background. Because for example, a simple kind of thing I can tell you, and this is actually from a relative of mine who is a smoker, talked to him so many times, had that same have actually about 55, and he's a smoker. That is expected because with every puff you're putting a lot of pressure in the lungs, and that's causing the heart to work harder against that pressure, you know. So,
What does RVS stand for?
right ventricular systolic pressure, which is the pressure that the right side or the right ventricle has to push to deliver blood to the lungs. Yes.
Under treatment, you have some comments regarding exercise.
Yep. And that was kind of my the final portion of my talk is then how does pulmonary rehab help your heart? And pulmonary rehab, and kind of in my talk I'm going to say cardiopulmonary rehab, because both they share the same kind of principles and values, and both are equally important. Of course, there's it depending on the condition that the patient has, it's more directed to them. But overall, like I said, the principles they follow the same principles in a way or another. So, what is a cardiopulmonary rehab? It's usually a program of it's a program of education and exercise to increase your awareness about your lung and your disease, where you learn to achieve exercise with less shortness of breath. Okay, so that is the goal of pulmonary rehab. And I actually like when I placed that in definition, I really liked how they mentioned the word awareness, because I can tell you the number of times where I sat down with patients and I explained to them what their condition is. It's I mean immediately you can see their shoulder drop, and they because now they understand, because a lot of the anxiety and concern comes from not understanding, and that's kind of part of the reason I was happy when I was asked to give this talk, is because that's a very important part, right? Understanding what your condition is and what does that entail and what to expect. It's very important. So always kind of ask about that, and I'm glad that clearly that you guys all care about it, because that's why you're here, right? It is to try to understand. Um, so that is kind of the definition, and the classes are either offered in a group setting or an individual basis to meet the and usually they're made in classes so you can meet other people, and it provides an opportunity to give and receive support. And that's why kind of we sometimes do it in group, is because a lot of times when you feel like you're struggling by yourself with the condition, it feels lonely. So that's why a lot of times when you meet others, it just gives you an understanding that you're not alone in this, you know. And I understand that kind of us as the doctor community or the physicians community, we definitely have a lot of ways or a lot of room for improvement in that regard, in helping and supporting our patients. But in the kind of that's what also one thing that when we kind of send our patients to rehab, is that's one thing that we definitely hope and expect our patients to gain from. The skills and knowledge learned in these programs will help you feel better and help you understand your chronic lung issues. And as you exercise or as you involve more and more in this, usually rehab program, we expect you to, or the expectation is for your level of fitness to improve, your quality of life improves, and hopefully even your the longevity or how long we want to keep you around improves as well. And the biggest thing that across the board for different rehab programs, specifically for cardiac and pulmonary, has shown it always decreases risk of hospitalization. So that's why it's actually from in all our guidelines, the cardiology guidelines, it's a level 1 recommendation, meaning we always have to recommend it to our patients because clearly there's a benefit. And as you can see, it's not an added medication, it's not an added procedure or surgery. It is actually it is work. It is work, and sometimes can be hard work, right? We don't live like across the street from the hospital, and it takes time and it takes effort. We have our loved ones drop us, taking us to those rehabs, but it's all because even though kind of all that's hard work, it's still better than the hard work that will be done if we do not engage in pulmonary in rehab programs. And what and those rehab programs, the hope from them is to improve different aspects of your health, improve in the peripheral vasculature, improve in the your muscle mass, your cardiac function. Clearly multiple studies show that it improves the heart function, as well as something called autonomic regulation, where how your heart, your breathing, and blood pressure interact with each other and different aspects of your body. Um, and one thing I wanted to emphasize in this talk is the importance of early initiation, because it's not only kind of initiating it, but also initiating it early is very important. Okay, because what happens when cardiovascular diseases are present is you start forming kind of not so healthy lifestyle habits or lifestyle changes, right? You start to have less physical activity. You start to have a diet with reduced caloric or nutritional intake, and you end up having sleep disturbances. And sleep disturbances is very important point that should be addressed with each of our patients. Okay, so that's why it has to be a formally structured program. It includes both exercise, training, and guidance on how you're gonna gradually increase your physical activity. Okay, and it's also the important thing in these rehabilitation program. It's a dose-related potential, meaning the more you have from it, the more benefit you see from it. Okay, and exercise is medicine. That's a kind of, again, us, even a physician community, we don't emphasize on it, but exercise by itself is medicine. And that's why there has to be formal and staffing and we have to have enough staffing to guide our patients through that process. Okay, physical activity is essential for overall rehabilitation, and that's why it's a very important aspect. In addition to the other aspect you mentioned, which is diet, making sure that the medication they're on is the medication they need. They are regularly following up with their rehab providers, as well as their physicians in the clinic. Um, and it provides a critical dimension of care, as it provides structure of clinicians, ancillary providers, education, and resources to promote the daily physical activity as an important part of recovery, resilience, and wellness. And one kind of final point I want to emphasize is this graph, and I'll see if I can kind of zoom in into it. Nope. Okay. 1 second. And this is kind of what I wanted to point at, which is the importance of early initiation of rehabilitation. Because it's not only the initiation, it's just also it has to be as early as we can, right? And a big portion or part of it has to be done first actually in the hospital. And this is something, again, I do think that we have area or room for improvement in as providers in the hospital, which is whenever you have somebody with a disease, and this is across all spectrum of diseases, you have a period of time where there's a functional decline, right? You're in bed, you're sick, you're not moving, and once you reach that, and that's kind of, as you can see, it's kind of week zero. And what's important to point at is in that part or in that portion where you have the disease, if you are still trying your best in that period of time to get up and do some exercises, as you can see, there is a decline, that is kind of a given fact, but it's not as if you're in bed rest. So that's why, I mean, actually in our ICUs, we realized this early on, and that's why we realized that you might, if you ever pass in the ICU, you might see kind of the nurses or the staff are trying to push patients to walk at least around the unit, not because we like to torture you, it's because we want to avoid that drop or that decline. Okay, because as you can see, starting here is way different than starting here. Okay, and also here kind of to show the difference between then what happens when starting rehab at 1 week. As you can see, you have hospital, when you have hospital ambulation and early cardiac rehab, where you have nice thriving recovery and health optimization, versus waiting for 4 weeks, where you still have that recovery, but it's not as robust and quick. Because eventually those two will eventually cross, you know, all lines will eventually cross. It's just the chances of it crossing is is higher the sooner we start rehabilitation. And again, if, as you can see, going into a bed rest in the hospital and then no cardiac rehab at all is something we don't want to see.
Yeah, in pulmonary fibrosis, one of the pulmonary rehab, is there a portion that deals with the coughing aspect? Is there like a coughing therapy or something to help with that aspect? Because when you start coughing, then you're short of breath, and it just, that cycle.
I mean, I actually, I would love to call a friend there and somebody from maybe the pulmonary rehab groups.
Training, but that was coffee. But we'll do breath work and
Yeah, and kind of then the question becomes also, of course, one thing that we can help as physicians is trying to understand why is the coughing happening. Okay, because I can tell you a lot of times we are, first of all, making sure there's nothing else going on. Because if the coughing is happening because your lungs are congested, then maybe we should have your pulmonologist or see a cardiologist, and therefore determining, is your coughing coming because your lungs are congested because of maybe congestive heart failure? Is there something else going on? Meaning first determining what's the cause of coughing. Because just saying or knowing that you have coughing and then sending you to pulmonary rehab without kind of ruling out everything else is not the kind of the right thing to do. First of all, we examine all the reasons, we optimize your medications and as much as possible, and we kind of treated all those aspects, and then after that, the next thing would be in pulmonary rehab where we address that coughing, and then how can we help you with that.
Which hospital deal with the coughing aspect?
So I would probably say that. So the answer is complicated, but to simplify it for you, I would start with a lung doctor. Or actually, even so, if you are known to have a lung condition, it would be your lung doctor. But if you have, like, let's say somebody who has a cough out of nowhere, then again, it goes back to that our primary care colleagues, who would be the first line and first person to kind of help us understand, in a sense, direct you to see if you need to see a specialist after. Or sometimes it's some of our primary care are very well competent and very well equipped in dealing with this kind of even by themselves. But I would probably say if it's a nuanced cough or something that you've made an experience before, primary care would be the first person to see.
I can say for sure, we discovered that there is a very strong cause and effect between pulmonary fibrosis and GERD. So you should check and make sure
I mean, to kind of to your point also, I mean, kind of remember that slide that said kind of how do you know where the problem is? And again, it goes back to that history taking, blood work, examinations, and trying to understand more where the problem is coming from. And I hope I explain to you why are we sometimes, I know that doctors are guilty of ordering too many tests. It's not because we like them, it's because sometimes to understand the problem, we really have to kind of make sure we turn every stone and make sure we're not missing anything. Which kind of brings me to the last point of my talk is when to worry about the symptoms, right? Because that's a big concern. And the symptoms kind of on this slide is what we usually kind of have, right? Headache, shortness of breath, fast heartbeat, coughing, confusion, wheezing, and those are again, it could be coming from different aspects. I mean, if especially at any point you're concerned, you always see the doctor. But if you're having any of those, also I do recommend that you see someone, if not somebody you already are established with as a kind of a specialist, and at least your primary care doctor. But do not ignore them. I usually tell my patients, kind of, I mean, there's no strong age cutoff, but the older we get, it's that kind of mentality of oh, it will go away on its own, or yeah, I still have time. It that margin of error starts to shrink as we get older. So just kind of keep that in mind. So, but also what I want you to kind of also wanted to point out, because there's a lot of kind of close interaction between both, is kind of also symptoms of congestive heart failure, which is usually shortness of breath, fatigue on exertion, and a good way, and probably if you ever kind of seen a cardiologist, and usually that's how kind of we describe it to our patients, is a good way of measuring is always kind of keep in mind, or always have a standard that you're able to do. For example, walking 2 blocks around your neighborhood, right? Now you're able to walk 2 blocks around your neighborhood. If after a while you notice that walking those 2 blocks is becoming harder, or you can't do it, that means there's a problem, right? Because you are able to walk 2 blocks and now you're not. And I'm not saying, there's definitely changes or things that we're not able to do as we get older, to kind of your point that you can't run the marathon, but there are basic kind of simple things. I usually I would say I had patients who kind of their reference point would be walking from the house to the mailbox, 2 blocks. They usually have a nice walk. They usually take around the beach that now is becoming difficult, or they stop doing. That is definitely a red flag, and something that you need to kind of watch for. Chest pain, swelling in your legs, a dry cough, especially when the cough is dry. Weight gain, you notice you're gaining weight, but your appetite is none, or you're actually or you're not eating a lot, but or no appetite, but you're still gaining weight. That is definitely a red flag. Um, Nausea, loss of appetite, um, needing to go more frequently to the bathroom, especially overnight. So those are the kind of, you don't want to delay its symptoms. And also, always, whenever you're concerned, please get yourself checked out. That's pretty much it. Any questions? I hope that was helpful.
I want to mention two things. The first one is reiterate what the doctor said about exercise. I did exercise ever since I was diagnosed with pulmonary fibrosis till the day before they did my surgery. So that maintaining that strict rule for me when they refer me to the pulmonary rehab was a great deal of help on my recuperation. My recuperation was very fast, very easy. In less than 2 days, I was already up from my bed. So think about it. If you don't do anything, your body is going to have less energy. With that, with all the exercises that I did for all those years, 4 years, that was a great deal of help for me. So by all means, keep that. Okay, keep the exercises, whether it's here at the pulmonary rehab, whether it's at home or with the group. The second thing is that I want to say thank you to the doctor, and I want to let you know, everybody, that just the way that I got to the doctor, he is amazing, because I was coming in to do my exercises, and I walked by, he was entertained with his phone, getting into a meeting or something like that. And I walked by and I saw on his jacket that he was a cardiovascular
Same jacket.
doctor. So I walked to the room and I said, you know what? I'm going to go and ask him to see if he can just give us a lecture over there. And I went and I approached him and I told him, doctor, this is what I do. This is me. Would you be interested in give us a lecture about the heart and lung condition? So, doctor, thank you very much, Dr. Ammar.
Sure.
I
Thank you so
really do appreciate what you have done. Amazing.
Yeah.
You're a great person,
Appreciate it.
especially just to, get with somebody that doesn't know, was not your patient, some stranger that just walked by.
No, I mean,
And
definitely.
Just, yes. Okay.
Thank you all for coming.
Thank
I
you.
mean, definitely it's a weakness of mine. I mean, having one of the things I remember as a medical student, I had one of my loved ones who was in the hospital, and I remember walking into the room and I asked them, like, what's going on? Why are they doing X, Y, and Z? And she looked at me and she's like, I don't know. I'm like, doctors didn't explain to you? It's like, no. Like, they didn't say anything? No. And in my head is like, this is the last thing I want to any of my patients to ever kind of be in that situation. And I kind of at that moment I realized, like, no, I want my patients to know. I'm not saying I'm perfect. I'm working on it every day, but it's something that, again, we definitely we want you guys to be in the know, and because, like I said, knowing is power. You know, not knowing is once you understand what's going on. The number of times I have patients, their shoulder drop after I tell them what's going on and they understand it's amazing. So thank you all for coming.
Thank you, everybody. Thank you. I really appreciate your participation.